was recently announced publicly that Chicago Bulls guard Lonzo Ball continues to struggle with chronic daily pain and may undergo a third arthroscopic knee surgery to try to elucidate the etiology, the cause of his chronic pain. I'd like to walk through some of the things that his world-class medical team is likely looking at. Let's start with the anatomy of the knee. The knee is composed of four bones: the thigh bone or femur, the patella or kneecap, the shin bone or tibia, and the fibula. Removing the femur, we see some of the internal structures of the knee, including the medial meniscus on the inside and the lateral meniscus. The menisci are horseshoe-shaped pieces of cartilage that act as shock absorbers. We can also see the anterior cruciate ligament and the medial collateral ligament. He underwent an MRI which showed a meniscal tear. It wasn't publicly announced whether it was the medial meniscus or the lateral meniscus that was torn, but probability alone would dictate that it was the medial meniscus. He underwent arthroscopic meniscal surgery. It wasn't publicly announced whether he underwent a meniscectomy, which is a trimming away of the injured part of the meniscus and torn part of the meniscus, or a meniscal repair where the surgeon sutures, puts stitches in to try to put the ends back together. Both surgeries have advantages and disadvantages. The advantage to a meniscectomy, where they trim away the injured portion, is that usually athletes can get back to action sooner. The disadvantage is, because a piece of tissue is missing, the athlete is more prone to developing arthritis of the articular cartilage, the cartilage lining the tibia below and the femur above. The advantage to a meniscal repair is that it tries to preserve the integrity of the tissue by suturing it back together. The disadvantage is, once the suture is dissolved, if the injury hasn't healed, if the meniscus hasn't healed, you're left with a meniscal tear after the sutures have dissolved. He underwent the arthroscopic procedure and was expected back within 4 to 6 weeks. He continued to complain of chronic pain, so they performed another arthroscopic procedure, a debridement, where the surgeon goes in, looking around for any new injuries to the structures and flushing out any loose bodies or anything that could be a detriment to the integrity of the knee joint. However, he still continues to complain of chronic pain. So what is his world-class team looking at? In order to evaluate a complicated case like this, you have to have an organized structural approach starting from the inside out. The first structure, of course, that they will be looking at is the knee joint itself. And that's why they're thinking of possibly a third procedure to look around and see if there are any other injuries or anything else going on. However, any good sports medicine doctor knows that you always evaluate the joint below and above. So in addition, they will be looking at the foot. Overpronation or oversupination can change gait and change the kinetics. Any residual injury from a lateral ankle sprain or an old high ankle sprain can certainly cause pain up in the knee. In addition, they will be looking at the hip joint. Arthritis in the hip joint, a tear in the cartilage in the acetabulum or labrum can do this, can contribute. This is called referred pain, where the pain generator then refers pain down to the area where the patient is complaining of pain. Another area they may be evaluating is the lumbar spine. A herniated or bulging disc impinging on a nerve root can refer pain into the buttock and knee. Sacroiliac joint dysfunction can refer pain into the knee. Here is a picture of the sciatic nerve as it travels down into the foot. The patient can develop neuritis, an inflammation of the nerve on or about the knee, or, as mentioned previously, a bulging or herniated disc pinching on the nerve root as it leaves, or the SI joint irritating the sciatic nerve can refer pain. So that's the skeletal system. In addition, the next layer up, they will be looking at the muscular system. Here we have the gluteus maximus, the gluteus medius, and the gluteus minimus is underneath. Certainly a tendinopathy where the tendons attach to the greater trochanter area, a gluteal tendinopathy can refer pain. Piriformis syndrome can refer pain also. If the piriformis syndrome has gone into spasm, you see it's very close to the sciatic nerve and can refer pain into the knee. A proximal hamstrings tendinopathy with concurrent irritation of the sciatic nerve can refer pain. A quadriceps tendinopathy can refer pain. Patellofemoral syndrome, think of it as an abnormal tracking of the patella as it slides up and down, can refer pain into the knee and cause pain into the knee. After the muscular system, they would be looking at the skin. Any scars from the surgery that are irritating a nerve on or about the knee can cause knee pain. Then they start looking at more systemic things. Certainly vital signs. Someone walking around with a baseline blood pressure of 160 over 100 won't feel well. Someone with a resting pulse of 110 beats per minute due to an underlying medical condition will not feel well. A thorough general physical examination. Lab work, a CBC, to include looking for anemia, leukemia, infection. Comprehensive metabolic panel to rule out prediabetes, otherwise known as impaired glucose tolerance, or diabetes mellitus. Electrolyte disturbances, high or low sodium, potassium, calcium. A TSH for hyper or hypothyroidism. A SED rate to look for inflammation in the body, perhaps a C-reactive protein, another marker of inflammation. Perhaps he is being worked up for any element of autoimmune disorder with rheumatoid factor, ANA, vitamin B12, folate. Low vitamin B12 and folate can irritate peripheral nerves. Vitamin D and other lab work. As far as diagnostics and treatment plan, one option could be a diagnostic injection where they inject numbing medicine into the knee joint and see if Mr. Ball responds with less pain to elucidate is the pain generator intra-articular in the knee joint or extra-articular if he doesn't respond. Once the pain generator is elucidated, other options in addition to physical therapy may include platelet-rich plasma, stem cells, shockwave therapy, and other modalities that have been shown to help with orthopedic conditions. We all wish Mr. Ball and his family well and a speedy recovery.